I'm now going to go ahead and introduce the panel. We'll be joined by 3 additional people to discuss the legal, ethical, and equity challenges and considerations for allocation of scarce resources, particularly the use of demographic characteristics in decision-making. So we have Dr. Annika Setterstrom. She's the Chief Health. Next is Dr. Virginia A. Brown. She's an assistant professor in the Department of Population Health at Dell Medical School at the University of Texas at Austin. And last, Dr. Thomas Sequist. He is the Chief Patient Experience and Equity Officer at Mass General Brigham. And so I'll start with this panel with the same question I asked the last, which is just to give me a couple of minutes of your thoughts about the presentation, and then we'll open it up for questions from the audience.
Great, thank you for the opportunity and the great presentation that was just presented by Govit over here. I have to say that I think that it was a very good summary of where the issues are. It was really well done, put together in a format that brought all the issues to the forefront so that we have a clear understanding of where the questions remain versus the things that I think have already kind of been agreed upon. And I appreciated having the questions at the end, because I think that that's where the goal of these conversations need to be, is to discuss the stuff that aren't the easy things to address and move forward. I am one that many of my colleagues have said, and I'm in the literature saying that there's a big proponent of race being a requirement. And it's definitely one of those things that right now feels really uncomfortable and really problematic to try and figure out how to operationalize. But I don't think that it's something that could be shied away from if we're taking the concept of equity and addressing inequity seriously, specifically in the outcomes of how COVID has been, in figuring out how to address any protocols going forward, whether it's through vaccines or any other preventive strategies that need to be done. Having race be an outlier will just continue to manifest inequities, and it won't solve anything else. And I believe that staying in sort of the happy zone of using alternatives for race or substitutions for race with like the SVI or the area of deprivation index or zip codes or all the things that people have used as a mechanism to just make it feel better and cleaner to not actually say race, to me is just not being courageous enough to try and envision a world that we're trying to create that's different. We forget that we're working through 400 years of a solidified system that has not ever been different. And what we're trying to envision is a world that we've never seen. And in order to do that, we're going to have to be courageous to do the things that may be uncomfortable, that may worry about how the legal ramifications are. But again, a legal system that was never set up for this to be an appropriate way. So it's not like the legal system is not infallible. That's the entire reason why we have constitutional law authors and constitutional lawyers, is to address and change to fit a system that is better representing what we say we want to be as a country instead of what we actually are. And so I'm very excited to have more conversations on how to get there and how to envision that new world order that I think we can actually achieve if we just have the courage to do so.
Thank you so much. I'm super excited to get started. I appreciate that feedback. Dr. Brown.
Thank you. Thank you all for the opportunity to be here. I amplify everything that Neka has said and want to then challenge us and what Govind said as well, but I want to turn it on its head. I want to bring a different lens, add an additional lens of analysis to this. So as both a philosopher, an ethicist, and one who's in the Department of Population Health, I have to think about the implementation of these things. So not only do we think very deeply and constructively about the information that's available to us, what is race standing in? Is this a proxy? You know, the historical implications. We also have to think about the actual implementation and how do we get to this. So my flip on this conversation is really thinking about moving away from the typical things that we talk about as public participation to something that I describe as promises to the public, okay? Public participation is kind of like quasi what we're doing today. You know, we're here, we're talking about this, we have viewed the literature, We have written on it ourselves. We have taken stances on this issue. But we haven't seen community. We've seen the public, but we haven't seen community co-creating these standards. Yes, we have open comment periods. Yes, we have the opportunity for people who are organized to give those 3 minutes worth of conversation. But what we're missing, I would argue, from how do we rethink, as you see the sign behind me, how do we really rethink co-creating new standards that are made collaboratively with citizens at our side, right? So it's more of a promise to the public than it is public participation. I'm very interested in how we can rethink this process of engagement, rethink these standards, and in part, create a more transparent and trustworthy system that engages community at the table. I just don't want to hear your 3 minutes worth of public comment, right? We should be at the table. And so I want to throw that into the mix as we get ready to talk in more detail.
Excellent. Thank you. Dr. Sequist?
Hi, good afternoon. I would just add one other angle I think is important in this allocation of scarce resources is we've talked a bunch about how we would identify who sort of won the lottery or was identified through an algorithm to be given this scarce resource. One of the things that comes up in this space, and when you go into sort of real life and practically implementing this, is we are assuming in that process equal ability to access that resource once you've won the lottery. And what we see, especially during the COVID pandemic, is that's not true. That's not the case. So if you are, whether we're talking about ventilators and hospital beds, we know that there's not equal access to hospitals, or we're talking about vaccines or monoclonal antibodies. A lot of that depends on where your centers are that are infusing monoclonal antibodies, where your vaccine centers are, where your COVID testing locations are, but also how are you reaching out to let people know that information, that resource is now available to them. If you are, emailing people, well, then you've already, identified a certain subset of the population that you're going to be able to contact. So I think it's important for us to not assume equal access on the part of patients and community members to all of these resources. As we are developing our algorithms that identify people that have, sort of quote unquote won the lottery for these scarce resources.
Excellent. Aurelia is typing in a question right now. And so while she's typing, I'm going to take the moderative prerogative, put out a comment, and then ask everyone's thoughts to this. So as I've been thinking about this, one of the things I've been trying to do is disentangle race from racism, because for lots of reasons, for the sort of mental health and protection of brown and Black people. Like, it's not our skin that's the problem. It's people's reaction to our brown skin that's the problem. And so wanting to have to separate those things and say it is the systemic inequities that arise from people's reaction to how we look that is the issue, and what we should be doing is tackling those things, and not that there's anything wrong with these people who happen to look like me. And also with the COVID in particular, because there was so much initial distrust, I was concerned about, putting people of color in the front of the line and people being like, what? I don't want to go first. And so hesitant about saying that we were going to prioritize or target racial and ethnic minorities. And so for me, using proxies for race has been a mechanism to highlight social injustice, to highlight racism, as opposed to shying away from it. And so I would be particularly interested for Dr. Cedarstrom, who is thinking about a social justice angle and how to sort of best think about tackling racism and in a way that seems the best way to get at social justice. But all of us are really thinking about how are we best serving to do that. And also sort of within our legal framework. And then Govind, as a lawyer, you know, do we have to think about that within our legal framework? Point well taken. You know, laws aren't always just. Is this something that we need to, you know, try and take down just because, you know, just because it's a law doesn't mean it's right. And so how are we thinking about that intermingling of, you know, justice and what's right and what's the law and racism and race and all of those things. So I'm just going to toss it back to you guys.
Yeah, sure. No, thank you for that. And I 100% agree with you that part of the problem is that separation of race and racism. And using the proxies help for that because it allows for there to be targeted influence in areas that are that way as a result of racism. And as a result of that, the people who live in those areas are typically more in the ethnic categories of Black and brown, right? So it makes it feel as if progress is being done because it's targeting areas that are as a result of racism that way. But what I have found, and especially when we were doing our vaccine outreach and trying to address inequities from vaccines, as well as the distrust that you brought up earlier, what I found was even using the zip code way, which is what we did, we took the zip codes of the patients' populations that we know are the highest amount of people of color in it, that have the lowest socioeconomic status, and all the various elements that we all looked at. Even in doing that, we still didn't succeed at actually making a difference in who got the vaccines, right? Like even when we targeted and went to communities, I'm very excited and proud of the work that we did. We got a lot of people vaccinated, but it still didn't address the inequity in our city when it came to the COVID response. It still didn't address the bigger social issues that those who are sort of on the fringe of those zip codes didn't get. The people of color in the suburbs who have a higher socioeconomic status still were having negative outcomes as a result of their color, their skin, not because of how much money was in their bank or how much education they had. So until we just acknowledge that it is that race and racism are so intertwined that right now we have yet the tools to help people extricate themselves from the two. Until that happens, we've got to be deliberate and intentional. Like the goal is to get to a point where that can happen, but we're so far behind the eight ball on this that we've got to do some extreme deliberate measures to try and play some catch up because people's lives are being lost just because we can't be better. And I think that we have the mechanism to do that. It's just uncomfortable because it's envisioning something we've never seen. It makes people of the dominant caste feel like they're being bad by thinking about race, right? We got to get through the personal feelings of discomfort and the societal pressures to make it seem like colorblind ideology is the best way to be. And if I don't see your color, then I'm treating you like a better person than actually acknowledging how your color actually is you. So we've got a lot of work to do to make race be its own entity on its own outside of racism. But until then, we've got to be really deliberate and intentional and radical in making these changes.
So
in Virginia?
Yeah, pick up on a thread of that. I think that despite, as you described, the intentionality of identifying by zip code, by neighborhood, where marginalized communities are and getting out there in a forward way, is commendable. It still speaks to something fundamental that we as a system have failed to do, right? And that's something like this. We talk about, we need to reestablish trust. We need to reestablish trust in our Black and brown communities. And I'm like, no, you can't reestablish trust where it's never been established. So let's talk about that first. Okay. These are things Black and brown researchers have known, some of our white colleagues have known, but in the academy has been sort of marginalized as not necessarily the most productive way to tenure. Okay, if I can bring that into this space. So that information has been marginalized and relegated in large measure to not being front and center until you get something as ugly as COVID that really lays bare the inequity in which we live in this country. Okay, it tells us that we don't have the kinds of trustworthy relationships with clinical providers that we need. We're seeing that coming out now, that the message ought not come from the government, who has betrayed Black and brown communities for 400 years, for a policy system. You want me to go first in line for this vaccine that's relatively new? Oh yeah, you're experimenting on me. We saw a whole lot of this conversation. But I'd argue if we had a system that had better care of patients in a one-on-one, where we had health homes, where we could have these conversations with our primary care providers about, what does this mean to me? I read this terrible thing. I'm afraid that, as I heard in an earlier panel, the physician who had just come off of service, talked about losing a young patient whose parents had gotten vaccinated, but she hadn't, because she read horrible misinformation, on the internet, and chose not to get vaccinated and is not likely to survive that admission. I would argue that if you had a health home and you had a physician who could talk to you that you trusted, because that's where the trust begins, that these conversations we'd be having now would be very different. So it suffices to say that what has to be done is not only rethinking what crisis standards of care are, but rethinking our entire engagement with the health system. And again, most importantly, figuring out how to bring what we call citizen scientists into the conversation. I have a PCORI award, a Eugene Washington Engagement Award, that has allowed me to really dive into what does it mean to do engaged research, not advocacy. Okay, advocacy is good, but engaged research is something different. How can we move forward and create the kinds of spaces where we have engaged citizens who are co-creating these standards, whose voices aren't heard in opposition, but heard in development of, who co-create these kinds of standards, so that the next time this happens, and we know it will happen, we will be in another situation of having to distribute scarce resources, whether it was the power outage that we had here in February in Texas, okay? Quite scary, and I come from the East and I'm accustomed to blizzards. You've never seen anything like this.
Right.
We really have to rethink co-creating these standards, not with the public engagement, but really flipping it on its head.
Excellent. So Dr. Sequist, I'm going to ask you, because these issues are not unique to the Black community. You get a big signal in the Black community, but I know that you have done a lot of work with Indigenous communities throughout the country. How are you thinking about this? And in your daily work, and just in your thoughts?
I think that this past, I guess 20 months now has been really interesting, as almost like a social experiment around rationing. I think that the country was on large scale introduced to the starkness of healthcare rationing, rationing of healthcare resources at a level that has been experienced for decades or centuries by subsets of our population, but has probably never really been experienced at the scale that the entire nation experienced it over the past 20 months, especially when you go back to the spring of 2020. So and the responses around that I think have been really, really interesting. There is a lot of, as you have pointed out, there's lots of concerns that are raised around, well, if you prioritize that population, are they sort of cutting the line? When the data would suggest that they are far from cutting the line, and you're actually not even going to get them up to the front of the line, even with the prioritization that you're doing. But the fear of what opportunity am I going to miss out on, and or what advantage am I going to lose that I've always enjoyed over time is something that has played out, I think, in really, really stark terms, and people sort of vocalizing their concerns over that who have been in the advantage over time. I think that among indigenous populations, if you go to tribal communities across the country, so this is a population that has since the beginning of the creation of the Indian Health Service, let's say if you go back to the 1950s, has intentionally had such restriction of resources, right? It's sort of funded it, 50% or less of the resources that it should get, right? So, spends maybe, let's say, $4,000, $4,500 per patient per year, where, U.S. healthcare spending is closer to $9,000 or $10,000 per patient per year right now. So it is intentionally a resource limited environment. I think what happened in the COVID pandemic is you see basically an environment in many of these communities that are very rural, sort of lack basic, clean water supplies, electricity. But ultimately, what you see is that the impact of COVID was quite similar to urban environments, which is the notion that systemic racism, poverty, and other factors allowed COVID to sort of run rampant among these communities. I think they had challenges, some logistical and supply chain challenges that you may not see in a larger city. It's a little bit more unique. But I don't see that there is a large difference between the challenges we saw here in Boston and the challenges you can say on the Navajo Nation, in the sense of it's all a result of, I think, policies that have not had a side effect of marginalizing these communities, but these are policies that were intended to marginalize these communities. So we shouldn't be surprised by that. But what we should do moving forward is to take action to try to combat that. So the point you're making around, how do we think about the concepts of race, racism, and health outcomes is really critical. We can't, there's a couple of things that I think about this space. One is that we can't be afraid to talk about race and racism, and that those are two separate concepts, as you're saying. But we also have to be really vigilant about understanding where race and racism are creeping into our healthcare decisions and our delivery system. There are basic things that when you think about SOFA scores, and in the prior presentations from the last panel and in this panel too, it's been discussed. When we talk about use of SOFA scores, when you use of comorbid conditions like chronic kidney disease or even just age, we have to recognize that the Native American population is younger than the general population, which is a result of racism, not a result of that my skin is brown. That the Black community has a threefold higher incidence of chronic kidney disease, and that is going to be a factor in allocation of ventilators if we use a traditional SOFA score. Should you hold that against somebody when the reason for the threefold increased risk of kidney disease is because of hypertension, which is related to diet and other things that are really a result of systemic racism? Again, it's really important for us to make sure that we understand when we're incorporating these kinds of data points into our decision making and the rationing of resources, that we understand the difference between race and racism and the implications of their use, because this whole concept of racialized medicine is really pervasive, and is something that it's like a 24/7 job, right, to constantly point this out as we make really important clinical decisions for our patients.
Yes, thank you. And so that brings us back to Govind and you talking about the intertwining of a lot of these factors and folding them into some of the how we're making some of these decisions around scarce allocations and the use of the SVI. And so can you talk a little bit more about your thoughts?
Sure.
Govit is an active parent.
I'm sorry, I have a 3-year-old that's home because of COVID exposure at school. He's fine, but he can't go back until Thursday. So let me just mute for a sec.
Don't worry, Govin. We've all been there. Don't worry about it.
And do we need a new panelist to join us?
So on the SBI, no, I would, but I think he's frustrated because he wants to watch Daniel Tiger but can't go down. So here's what I would say about the SVI. I disagree with the idea that we should think about the SVI as a sort of a proxy for race, or the idea that it's adopted because people are scared of talking about race or something like that. I would say that I think of the SVI as a metric for trying to get at intersecting disadvantages, which often result from structural racism. So this is the intersection. And if you look at SVI, I think this is in some work that Dr. Peek and I have done. It's not that it excludes race, it's that it thinks about race from the perspective of a neighborhood variable rather than individual racial identity. And interestingly, there's a discussion about this in Oregon, back when Oregon was doing their vaccine allocation. And both the caucus of, I think they called themselves Black, Indigenous, and People of Color legislators, and the Oregon Health Authority director, Rachel Banks, I think said that they preferred a sort of SVI type approach over using individual race, in part because they thought it was more operationalizable. So the quote was that they thought that it was more operationalizable than having people individually sort of prove how they fit into a specific demographic group, was what the caucus said. So I think the other thing that I'd be curious about in sort of the question of zip codes, I think the zip codes, as opposed to if you talk to demographers about zip codes, I've been doing some work with a professor, Elizabeth Wrigley Field in Minnesota. They argue that the census tract is a much better way of trying to identify, that sort of is a much better way of trying to track SVI and these disadvantage indices than trying to do it at the bigger level of zip codes. And the question there is going to be part of why we use zip codes is I think we are still often stuck in this paradigm of what I think Dr. Peek and I and other work have called a sort of a passive approach, where we ask people to sort of show up somewhere and prove their priority for resources. And people know what their zip code is. If you use a more active approach, so there's a great paper in New England Journal of Medicine's Catalyst subjournal about San Francisco's approach. I think Dr. Kristen Bibas-Domingo might have been one of the authors on this. They, and some other folks at UCSF, what they did was they actively called, went door to door, reached out based on the sort of high vulnerability tracts. And so I think that one dimension, but I think also gets to this question that Dr. Sequist had mentioned of not just, are you giving people priority, but do they actually have equal access, is needing to shift from a mode of saying people need to show up and prove their priority to an approach of we are going to proactively identify the people who are going to get priority access. We're going to reach them by many different mechanisms to make sure that they have the opportunity to decide to receive vaccines early or access to antivirals or monoclonals or other treatments like that early. So I guess the two dimensions for me is that I do think there's a case for SVI that doesn't rely on the idea that it's a kind of evasion of race. And the other is that I think if we think about it at the level of the census tracts and through a proactive approach, so the more recent research I take maybe shows a more favorable picture for being able to use it to really remedy some of the disparities. I think there have been challenges with just these passive approaches where people said, oh, we'll set up a site in this neighborhood. And who comes to the neighborhood? People from somewhere else. So I think with these passive approaches, there are real challenges. I think using SVI with an active approach the way San Francisco did is a little bit more promising.
I'm going to use this opportunity to turn the conversation a little bit to another topic. Two questions have come in around implicit bias and provider education. And so one asked, to what extent has education of providers concerning crisis standards of care incorporated educational disparities in healthcare and the problems of racism and ableism? I don't know the answer to that. Maybe someone here does. And then another question is sort of Michigan has addressed in racial equity. One is access to primary care physicians who can order COVID tests and then get the whole family tested, as well as address comorbidities earlier, like diabetes, asthma, et cetera. The second is implicit bias training. Have other experts look at these issues specifically. So again, pushing us more into the area of clinical care, primary care, and training of providers around disparities in thinking about some of these broader issues. So I'm going to maybe ask Dr. Sequist to address this first, since I know you have some expertise in this.
I just asked, I don't know if it happened for others, but I didn't hear your second question, your video.
Oh, did I freeze? Okay.
Yeah.
Okay, so second, there appears to be two issues that the state of Michigan has addressed in racial equity. One is access to primary care physicians who can order COVID tests and then get the whole family tested, as well as address comorbidities earlier, like diabetes, obesity, asthma, and other known risk factors for COVID outcomes. The second is implicit bias training. Have other experts looked at these issues specifically? So those two questions together are looking more broadly at clinical care practices, primary care, the issues of training providers in implicit bias, and how those may be part of the overall umbrella of how we're thinking about implementation of crisis standards of care.
So I think it's, I can't speak for the whole country. I can say here in our system for the first question, I think it's critical that your team, so all crisis standards of care, when they get implemented, right, there is a process to implement those within a hospital setting. I think it's critical that you have both involvement of bioethics, medical ethics, and someone who's representing equity. And that those people have to have the same equal voice to your critical care doctors, your nursing leadership, and otherwise. And that those people have been trained and educated on the principles of how we are approaching, let's say, anti-racism or equity in the concept of our crisis standards of care. So we have those voices present throughout the development of the crisis standards of care, which has to obviously go in line with the state guidance as well. But then they actually are involved in the decision making if you actually get to the point of unfortunately needing to implement those standards. I don't think that there is another, going to be another effective way to do that beyond having them not only just there, but having the equal voice of everyone else in that group. I think that on the second question of are we sort of implementing sort of care patterns in our clinics and our clinical environments that helps address some of these comorbid risk factors and trying to address things upstream. Again, I would say I think that we need to, if we take this anti-racism lens to all of the work that we're implementing related to our COVID response, then of course we absolutely need to be proactively identifying patients who are at risk, for poor outcomes from COVID, actively reaching out to them and providing them with the resources and support that they need to hopefully eliminate any bad outcomes from COVID. That's a really challenging thing to do, as you might imagine. But I think what, in our system, what that involves is sort of retooling or pointing our population health programs And all of those resources in a different direction, our high-risk care management programs, our typical population health management programs, our primary care clinics, so that we are all pointing towards one goal, which is we are trying to prevent the worst outcomes from COVID, and those worst outcomes from COVID are going to take us to certain geographic areas and certain populations.
Great.
If I could just quickly say something about something that I would love to see more research on, especially interdisciplinary from things like psychology, is how to create situations for providers that minimize the extent to which implicit bias gets activated. There's some preliminary research that I think is really interesting and promising on how, when there's not clear guidance, where there aren't sort of standards for priority, people sort of fall back on intuitive judgments that tend to actually, people worry about, I think, a lot about bias in our formal standards. And I think that's important. But if you are resistant to having formal standards, you can actually end up with sort of worse, more biased outcomes, because some of the sort of most troubling stories of bias that I've seen have not been, in fact, for critical care, pretty much all, it's not that it's been a biased standard of care, it's that there was no standard and the doctor ended up making choices that looked like they were based on racist or ableist or other assumptions. So I'm interested in how we can think the psychology research suggests tentatively, if people are able to be reflective as opposed to using their sort of quick decision-making system, this can cut back on the way that implicit bias plays a role, but I would love to see more research on this.
Yeah,
Actually,
unfortunately. Oh, go ahead.
No, I was just going to say that I have a colleague who's actually doing that research. So I know that it's coming. Her name is Dr. Samreen Vora, and she runs the Simulation Center at Children's Minnesota. And she's actively looking at how developing sims around empathy building, right? Because this research right now is really clear that in order for there to be substantive change in our initial reaction in a situation is that we have to have a pretty significant dose of empathy for that person. And if empathy is not there, then we fall back into what we all term as our biases and the things that are sort of our cultural norms of how we see others, right? So empathy building, it seems to be one of those ways to psychologically shift someone's ability to not just auto decide and to actually take a second and make a decision that may be better interest for the person than what would have happened.
That is excellent, because the healthcare system is primed in all of the, I think there are 4 ways that lead us to lean into those biases. So uncertainty, time pressures, high cognitive demand, and there's one other. And so that's always going to be the clinical background in which we're working, either inpatient or outpatient. And so those are going to be constant. But if we, so that's, but if we can find other interventions that are mutable that we can bring into play, then perhaps we have opportunities for change.
Well, I think
go ahead.
There's an unspoken component to all these very important things that everyone has said. And it goes back to that question somebody was asking about, sort of in the clinical encounter, in medical education and training, what's going on. There is a huge power dynamic between being a medical student, a resident, a fellow, and attending, that while I am hopeful of the young people who are coming into medical school are better trained, I train them, I do some undergraduate baccalaureate training for ethics, where we're seeing changes and differences. Not everybody's on the same playing field. Not every medical school classroom has that foundational thing where it's okay to speak truth to power. Mm-hmm. So you have that dynamic, and another one. You don't have to, the second one, you don't have to be learned in all the words of, structural inequality, equity, equality, blah, 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 blah. You don't have to know that. You know that something is profoundly wrong. You need to speak about it. And you must speak out against the things that you see that don't make sense. You don't have to wait for all the elegant language, and all the master's degree learning, that some of us have done, to get a handle on these phrases, but to be able to speak them without repercussion is critically important to creating an environment where equity is possible.
Thank you. Thank you so much to our panel. This has been extremely exciting and fun to discuss with you guys these issues, which are sensitive but extraordinarily important to the lives of our patients, and to how we think about trying to address these issues from a population perspective, from a health policy perspective, that not just involves the patients that we see in our practice, but entire populations of people, and trying to mitigate disparities. Thank you so much to each of you. We are out of time for this session today, and I appreciate the audience for the questions that you posed.